Presenting today a talk, an interesting one, mainly about a clinical trial that is ongoing still from 2010. We did a recent update in 2026. We collected the data again, and we'll share with you the results that we have. Uh, First, I would like to acknowledge Professor Saleh Ubeda, and all the colleagues and mentors actually that I have in the Department of Ophthalmology, and especially in glaucoma unit, for the help and for the starting such a project and following up the patients. Here with us also, Professor Ahmed contributed largely to this study and to prior studies that will be mentioned today as well. So to start, what is congenital glaucoma? It's a defective development of the structures in the anterior chamber of the eye that results in impairment of aqueous humor outflow system. It's seen first at birth, but can present up to 3. Will subsequently cause pathological. We classify congenital glaucoma as usually is present at birth, but diagnosed maybe later on, as we said. Can be diagnosed in the first month or can be diagnosed up to 3 months in life. The symptoms sometimes recognized later in milder cases. However, in secondary glaucomas, these are other syndromes or ocular associations like in aniridia or anterior segment dysgenesis, Axenfeld-Rieger, Sturge-Weber syndrome, neurofibromatosis. Our talk, we will focus mainly about bilateral primary congenital glaucoma. So to define the types of primary congenital glaucomas, we have the primary newborn congenital glaucoma, and this is the most severe type, as we know. These patients present at birth. They have one that we see here in our country, and they have a very severe disease. The other type is infantile glaucoma, which usually are they are recognized later on from 1 month until years. In some publications, 2 years. Talk about that later. And in the primary juvenile glaucoma is clinically apparent after 3 years of age. 3 years of age is generally taken as a division between infantile and juvenile glaucoma, because after this age, the eye no longer expands in response to raised intraocular pressure. And juvenile glaucomas, they don't have corneal enlargement or have striae. The pathomechanisms of the primary congenital glaucoma is talked about and debated a lot. And when you go to the literature, you will not find one mechanism or a multiple or a group of mechanisms. There are postulated theories like abnormal thick trabecular beams, absent intratrabecular spaces in the deeper layer of the trabecular meshwork, presence of amorphous material in the Schlimm's canal on the subendothelial region, and totally or partially absent Schlimm's canal in almost 4 to 20% of cases. There is also theory about the absence of imperforated membrane, which is called Barkan membrane, postulated by Barkan in 1955. However, it was not proven to be there histologically or by electron microscopy. Regarding the genetics of the congenital glaucoma in Western Europe or in Western countries, most cases are isolated and most cases are sporadic. 10% were familial, usually autosomal recessive pattern with incomplete or variable penetrance, and the genes associated are many. In our population, it's mostly CYP1B1 and LTBP2, and we'll talk about that. In our population, mostly autosomal recessive. There are many publications focusing on that. In the Western region, there is a recent study published in 2014 and showed that 80% of cases of congenital glaucoma presented there had CYP1B1 mutation. The prevalence of congenital glaucoma, as you know, it's more common in our country. In the West, it's around 1 to 20,000 cases, the incidence, or 1 in 25,000 newborns in some studies. In the newborns, even more common in the Rome population of Slovakia. It is also common in India, where almost 1 in 3,000 is affected with congenital glaucoma. Uh, the leading cause of childhood, and this creates a burden when you have a incidence like this. There was a study published in 2017 by Dr. Ridwan Malik. It reported that they had in Kekesh uh, an average of 70 cases for 15 years consecutively for the last 15 years prior to the publication of the study. And as you know, these patients will require surgical treatment, often multiple surgeries, requiring lifelong follow-up, and this creates a burden on the healthcare system. So let's quickly go to the disease itself on the evaluation. As you know, the symptoms usually for the infantile type in general are epiphora, photophobia, blepharospasm, but we usually, our cases are striking and can present at birth with usually ophthalmos, cornea, corneal haze, HAB striae, increased IOP, of course, and optic nerve cupping. For evaluation under GA, the first thing that we do usually before intubation is tonometry and getting the IOP. This is important because anesthetic agents and intratracheal intubation affects IOP measurement. And then we go and look for an external examination for the patient for looking for syndromic changes like port wine stain or other causes of secondary glaucoma. Anterior segment examination, of course, and assessing the corneal diameter and corneal clarity, gonioscopy, fundus examination, taking the central corneal thickness with pachymetry, taking axial length and B-scan measurements as well, and optic nerve assessment and photography in the examination. We usually also do refraction with a pediatric ophthalmologist in the EUA with our pediatric colleagues. For the tonometry that we use is usually Perkins or Tonopen, and should be, as we said, measured early prior to intubation and after induction of anesthesia. As most anesthetic agents can, they usually generally reduce IOP, but actually some agents can cause elevation IOP, especially succinylcholine. These are the Perkins and Tonopen that we're usually using in the university. So the treatment of congenital glaucoma, as we know, it's a surgical disease, and the role of medical treatment is only to reduce the IOP until surgery is performed. Clear cornea, also another indication for medical treatment prior to surgery is to clear the cornea for a possible intraocular surgery if planned, and achieve post-op control till adequacy of surgical procedure. The medications that we use for congenital glaucoma, the first line is topical beta blockers, and the second line are carbonic anhydrase inhibitors. We usually combine these in a single drop, like Cosop or Razarga. Others we go for prostaglandin analogs, usually in the university as the third line. We don't use alpha agonists are contraindicated in newborns and in children below 3 years as they can cross the blood-brain barrier and cause apnea, hypotension, bradycardia, hypotonia, hypothermia, and somnolence. We almost never use pilocarpine in the university for children. For the surgical management, if you go to the literature, often multiple surgical interventions are required. And the goal is, of course, to normalize and permanently control IOP of medications, clear the cornea, and prevent progression of disc-cupping corneal changes, preserving vision and visual field and ocular integrity as well, and to stimulate the development of binocular stereoscopic vision. The surgical options, historically, as Professor Sam said earlier, goniotomy is the most commonly performed in Europe. As we know, we'll talk about all the procedures here. Trabeculotomy became popular later on, especially in the cases where the cornea is not clear. And then what we used to do in the university was to combine trabeculotomy with trabeculectomy, which gave better success rate. And then later on, we moved to deep sclerectomy. And now there is a talk about microcatheter assisted circumferential trabeculotomy or a circumferential trabeculotomy in general. So to start, for goniotomy, it's, as we know, more goniotomies in adults with Kahog dual blades. It requires a clear cornea. Visualization of the angle in a we almost don't do it in the university, as almost all of our cases have hazy corneas to start. The advantages, however, in goniotomy is that you don't injure the conjunctiva. You don't have bleb complications. It's safe. It's rapid. It can be repeated as well. It's much less traumatic than other surgeries. However, cloudy corneas and does require some surgical experience. The overall 12-month success rate in goniotomy is around 70% in single goniotomy and 90% in two goniotomies. But in our population, it is less than that, and we'll go through our studies as well later on. For trabeculotomy, the indications, it became more popular because goniotomy, as we said, if you have the cloudy cornea, you cannot do it. And the results in certain populations are not promising. So it is technically tried in Europe after two failed 120 degrees goniotomies, and it can be combined with trabeculectomy for an increased success rate. The success ranges from 70 to 100%, depending on the study and the follow-up. And the procedure utilizes an external incision, and then you identify the Schlemm's canal, and you use this trabeculotome with two prongs, and then advance it and penetrate and enter the eye. And then you just close the conjunctiva. And the advantages of trabeculotomy, as we said, it can be done in opaque corneas. It has a high success rate. It can be, you don't need a lens to use it, but that's not an issue anymore these days. But the disadvantage is you don't visualize the angle directly. You may go possibly to a false passage, and Schlemm's canal is not found in 4 to 20% of cases in the literature. Hypotony and hyphema are much more common as well. And the success rate, if you go through the studies, the overall success rate is reasonable in general. It hovers around 70 to almost 93%. In our population, the complete success rate was this study was done by Professor Vedan. It was 45% for complete and 75% for overall success rate for a mean follow-up of 5 years. And these procedures are getting more and more popular nowadays. And ab externo 360 trabeculotomy, again, it's like going through the trabeculotomy, but instead of passing a trabeculotome, you just pass a flanged or a cauterized tip Prolene suture 360 with or without a microcatheter, and getting the suture from the other end, and then doing a 360 trabeculotomy. Or it can be done with an ab interno approach, similar to what we do with GAT in adults. Probably it would be safer to use a microcatheter, but like iTrack Advanced or the Glaucolite, and we have these in the market, as it will tell you exactly if you're going through a false passage or through the correct way. The results for the 360 trabeculotomy in general are good, but these are not in our population. I know that they are undergoing a surgery in Eastern Province, I think with Dr. Al-Habish, but I couldn't find any study in our population. But the success ranges from 60 to 90, 95%, the overall success. Regarding the combined trabeculotomy trabeculectomy, it adds it increases the success rate for trabeculotomy compared to trabeculotomy alone. And as you can see, the success rate is higher in almost across the board compared to the other trabeculotomy alone. And when we go to this study done by Dr. Al-Hazmi in 2005, it highlighted that In mild cases, goniotomy had a good success rate, almost around 81%. But in moderate cases, it's almost like 13%. For trabeculotomy, the success was 90% in mild cases, 40% in moderate, and 10% in severe. But if you combine that with trabeculectomy, the success rate for the moderate and severe cases jumps to 80 and 70%. So doing trabeculectomy with trabeculotomy and adding mitomycin C does increase the success rate, but it comes with a drawback. It increases the complications of the procedure as well. So deep sclerectomy became popular with time, and multiple reports have been published about the efficacy of deep sclerectomy in treating congenital glaucomas. This study was published by Prof. Bedan and also Professor Ahmad, and showed that deep sclerectomy is effective and it's worth to be the first surgical option in congenital glaucoma. But there is no direct comparison study at the time between deep sclerectomy patients, deep sclerectomy and combined trap in our population. So this clinical trial was started in 2010 by Professor Sam and Dr. Saleh Bedan, deep sclerectomy versus combined trap in bilateral primary congenital glaucoma, and 2026. Efficacy and safety of both procedures and detect the type of rate of and to improve the guidelines for management in congenital glaucoma. The major outcomes were reduction in IOP, in Hayes scale, number of medications, differences rate and type of complications, and improvement of any in-cup disc ratio or corneal diameter, if any. All cases were bilateral. Right eye always had deep sclerectomy, and left eye always had combined trap. Mitomycin was used for all cases in both. The exclusion criteria was secondary congenital glaucoma, previous surgery in any of the eyes, unilateral primary congenital glaucoma, and lost follow-up. The criteria for success was complete success, as we know, IOP 21 or below without medications, qualified success 21 or below with medications, with maximum 2 classes. Failure is IOP above 21 on more than 2 classes of medications, or eyes requiring further surgery. Our sample was 68 eyes in both arm, and the sample was 136 eyes of 68 patients. The results of our study of our we have 40 patients who were female, 58% of them. The mean age of surgery was 47.7 days, and 16 months, almost 7 months to 180 months. The preoperative findings, we had the average IOP for our cases was 31.3, plus minus 6 standard deviation. Pre-op medications were 2.2 by classes, plus minus 0.5. Corneal clouding was reported 134 eyes out of 136 eyes. Almost one patient had not reported in the file that they have corneal clouding. The mean corneal diameter was 12.36, measured by a caliper manually. 30 patients had family history of congenital glaucoma. That's 60 eyes. Upon taking history, they admitted that they have a close family relative with congenital glaucoma. So we'll start first by our results with the complications, intra and post-operative complications. You can see in the deep sclerectomy group, intraop complications were minimal and not significant. Macro and micro perforations in 4 patients, and the combined trap there were more cases having zonular fixated lens and iris dialysis as well. In the deep sclerectomy group, 2 patients had shallow AC, 3 patients had hyphema. 1 patient had a vitreous hemorrhage and turned out to be also had shallow AC. 7 patients have updrawn pupil. 4 of them had pupilloplasty later on. 2 induced cataract. And as you can see, the complication rate overall for deep sclerectomy was around 14% and was 49% in the combined trap-trap group. So regarding the results, we did a 5-year success rate and then an overall success rate. For the 5-year success rate is to compare it to other studies following for 5 years mainly. The overall success rate for the deep sclerectomy group was 75%, and 50 eyes or 73% had complete success. 1 eye only had qualified success. 17 eyes failed. For the combined trap-trap group, 49% of the eyes survived. That's overall success of 72%. 46 eyes had complete success. 3 eyes had qualified success, almost 4%, and 19 eyes have failed. The overall success for the whole duration of the follow-up, this 116 months, the survival rate was also telling a similar story. It was almost similar, slightly better in deep sclerectomy group, but not in a statistically significant way. 43% of 43 eyes of deep sclerectomy group, or 63% survived with overall success. 60% of them with complete success. In the combined trap-trap group, the overall survival was 58%, and the complete success was 55.8%. 25 failed eyes in the deep sclerectomy group, and 28 eyes failed in the trabeculectomy group. The variables affecting surgical success, the most important, the statistically significant variables were 2: the preoperative IOP and the degree of corneal haze. The degree of corneal haze was the strongest variable affecting outcome. Those who had mild corneal haze on the scale from 0 to 4, those who had mild corneal haze had better surgical outcomes in general compared to those who presented with severe corneal haze. And those who had IOP below 25 had better long-term results compared to those who had a very high IOP to begin with on medications. Regarding IOP reduction, the mean IOP in both groups was comparable. It was 15.4 plus minus 4.8 in the deep sclerectomy group. In the combined trap-trap group, it was 15.28 plus minus 5.3. And the number of medications was the same. And that includes, of course, the failed cases. Regarding the failure, interestingly, the mean time of failure was longer in the deep sclerectomy group. It was around 45 months, or plus minus 40 months. In the combined trabeculotomy trabeculectomy, it was a shorter failure, associated with a shorter failure time of around 34.1 plus minus 40 months. And most importantly, the next slide, when we talk about the final visual outcome, which is most important, in the deep sclerectomy group, more patients had a better visual acuity, 20/40 or better, compared to the combined trap-trap. 38 eyes had a better visual acuity, 20/40 or better visual acuity, compared to 27 or 39% of the combined trap-trap group. And on the other hand as well, deep sclerectomy group had less patients with vision worse than 2200, 11 only compared to 16 in the combined trap-trap group. And in our study, 42 patients at least had 1 eye with best corrected visual acuity of 20/40 or better. Now, the reason for this is, for me, while collecting the data, it's difficult to tell. I haven't done an analysis of why, but it seemed while collecting the data that the combined trap-trap group had much higher astigmatism values in refraction. The conclusion for this study, or this data so far, is that deep sclerectomy, it is safe, it is effective in treating congenital glaucoma. It has a better safety profile than combined trap-trap. It is less invasive, and it had a superior visual outcome compared to combined trabeculotomy trabeculectomy. Early diagnosis and prompt treatment can preserve vision, as we all know, and the responsibility of the surgeon does not stop at the surgery. These patients require lifelong follow-up. They can fail at any time. Some patients in our studies failed at 16 years after being off medication for all that period. Visual rehabilitation, as we said, is equally important as IOP control. An attempt should be made to familiarize the parents of and the patient when they grow older that the course of illness is refractory and they require lifelong follow-up, and to note for them the importance of amblyopia treatment. Some of the patients had good IOP control throughout the study, but they had poor vision, at least in one eye, because of the amblyopia treatment. They didn't take amblyopia treatment seriously. Preoperative corneal haze and IOP, high IOP, were indicators of the, or low IOP to say, were indicators for the success of surgery. And thank you.
Thank you very much, Dr. Faisal, for a nice presentation. Actually, we can open the floor for discussion now. If you have any question, please. If no questions, I can start one slide here. You mentioned that brimonidine should be taken before 3 years. Actually, it is 10 years. Or according to the weight of the... You agree?
Yes. We don't usually give it. It's in the books in 3 years. I know we don't usually give it at least 7-8 years. No, I don't think anyone is giving it enough.
Another question I want to ask you about penetrating deep sclerectomy in babies with congenital glaucoma. What do you think? And I want to ask also everybody, you go for non-penetrating, there is 2 cases of micro and 2 cases of macro perforations. I am happy when there is perforation during congenital glaucoma surgery. What do you think? Anybody can comment in that? Dr. Faisal?
The cases with perforation also.
Yes. Dr. Judan?
Very nice presentation. I totally agree that deep sclerectomy is much safer and much better than any other procedure for primary congenital glaucoma. Regarding the perforation or no, actually I don't become happy if it's, but I'm at the same time not unhappy. So my, preferred outcome is non-perforation. If there is perforation, especially if it's micro and you don't need iridectomy, it's not a bad complication. I have 2 questions regarding the study. Number 1, regarding the surgeons, is how many surgeons are involved in this study, especially with the number of cases you have done?
Yes.
And the second question is, if you looked at the cases with family history rather than the ones with no family history of the disease, did it make a difference?
Regarding the cell, we have 4 surgeons, Prof. Sam, Prof. Bedan, 5, Dr. Arifi, Dr. Sujuman, and Dr. Mubarak. The most cases were operated by Prof. Saleh Al-Bedan, around 50%. And regarding the family history, I didn't include it in the analysis. It would be interesting to see. I was reluctant actually to include because in those who, when we look at the file, in those where there is, they don't mention that there is sometimes no family history. And maybe the parents, they don't know that they have a family history of congenital glaucoma. I don't know, but it would be interesting to see the results. I didn't do the analysis for this one.
Dr. Malik, you have any comment about penetration, not penetrate? Especially, congenital glaucoma, if the pressure raised, you cannot do goniopuncture. This is another, okay, after.
Thank you. Well, I mean, I'd like to congratulate you, first of all, on producing randomized controlled trial evidence. We often adopt a practice, but we don't know, is it better than what we're doing at the moment? What's interesting is I found that what your results really show is that TNT is as efficacious as deep sclerectomy at 5 years, right? Yes. Success rate's about 60%.
Yes, it's about this. In 5 years, it's 75 for deep sclerectomy overall, and around 72% for combined.
Right, and statistically it's the same.
The same, yes.
Statistically, yes.
So that to me was the most important finding. I mean, we can look at more intricate results like complications. Complications are few, so difficult to compare between the groups.
Yeah.
The other advantage of deep sclerectomy is that you probably need less post-op interventions and visits compared to trabeculectomy. I mean, I use releasable sutures if I'm doing trabeculectomy. So at 1 week, you need to remove the releasable suture, give subconjunctival a few injection. So that's another advantage which you could possibly look at. An interesting question which comes out of this is, are there certain types of patients who might respond better to deep sclerectomy and other patients who might respond better to TNT? For instance, if you have very advanced glaucoma where the angle is damaged already and the cornea is cloudy, maybe those patients do better with TNT. And I don't know the answer, but it might be something we're looking at.
This is a very good question. You can answer.
Yes.
I think you mentioned in the study the failure mainly for those who have more haze in presentation.
Yes.
I think you mentioned.
Yes. I tried to correlate if the first eye failed, will the second eye more likely to fail or no? And it wasn't statistically significant. Sometimes the right eye would fail, sometimes the left eye would fail. What is also interesting is that the failure time in combined trap is, and they fail earlier when they fail.
Actually, show your results for your failure time. I'll just point something out.
This one, yes.
Yes. So if you look at the mean, look at the standard deviation, it's actually similar to the mean.
Similar, yes, yeah.
I'm pretty sure this is not statistically significant.
Yes, it wasn't.
Dr. Laila?
Thank you so much. So I know deep sclerectomy, if you don't do penetrating, but these are kids and usually they rub their eyes and it's a very thin membrane, so it could be like vigorous rubbing can open can perforate the trabecular meshwork. So can you do OCT for the patients, especially you had them for 10 years and now they're like teenagers, you can sit them on the OCT and do ASOCT to find out if they are perforated now or no, or there is like somehow.
I'm now collecting the corneal thickness of these patients, so we can sit them for sure on OCT. We're also doing OCT. I don't think that we have a good anterior segment OCT machine that would tell you if the angle is open or no in the university, but it would be interesting to note, of course. What do you think?
Maybe we can find an answer to this debate.
Yes.
Penetrate or not penetrate.
It's a good idea. You can try.
Yeah.
And I think if you do like for the DS groups, if you do genetic testing for them, at least for the CYP1B1 mutation, if they have a CYP1B1 mutation, then they have a like trabecular meshwork dysgenesis, and yet DS is working in these groups. Trab and trap will be whatever the if you have a trabecular meshwork and we don't have, you will be having a success rate.
Yeah.
But DS depends on the development of the trabecular meshwork. So if we find out that if they are CYP1B1 mutation, we can then correlate. Okay, even if you have a severely damaged trabecular meshwork, still DS works.
Yes.
Any other comments, please, from other colleagues? Dr. Conrad?
Thank you, Dr. Essam, and thank you for such a great update. We were in 2024, we published a paper on comparing the penetration of the DS versus non-penetration. And I totally agree with Dr. Jedan. I don't like to have a penetration during my DS, but what the paper showed was that at least in a time of 15 months, it was not main difference. And now we are planning to publish a new one on 10 years follow-up of cases of Dr. Jedan, in which it has an excellent outcome, whatever happens, no perforation versus perforation. Mm-hmm. So I think that the DS give us the extra safety, but if a perforation happens, at least at the end, the outcomes are the best, are the same thing. Thank you.
So why not to come to conclusion between the two opinion? And my opinion, personal, if a mild case, if you do anything, it will succeed. So mild cases, I like not to perforate.
Agreed.
If there is good percolation during surgery and the case is mild, presenting IOP is not high, cornea is not that haze, I don't like to perforate, better to be non-penetrating. But in severe cases like severe corneal scar, presenting IOP is high, I like to penetrate, to have more routes of drainage actually.
But you mentioned the key of this. You have to have high percolation. If you don't have, and I
Yes,
always said
yes,
that to the
yes.
fellows, you keep digging and digging and digging. And
Yes,
that
yes.
is why the name is deep sclerectomy. If you stay too shallow, then it will not work. I'm agree with you. You have to get the whole chances at the setting and try to have at the end a good percolation. Absolutely agree, Dr. Reza.
Thank you. Any other comments for our glaucoma specialist? Dr. Naif.
And I agree with what Dr. Leila said regarding would specific mutations predict the prognosis. It might be a good idea, but to start such a project is...
Yes, yes. Dr. Naif,
Yeah,
please.
regarding the, thank you for the presentation, and
Okay.
it was really great, and for the update of 10 years work now. For the perforation, I think I would go with the idea of not perforating the DS, even in the kids. I think the thing that gives the deep sclerectomy this success, long success, and the safety is the slow filtration. It's not the rush of the,
Not like trap.
not like the
Yeah.
trap. I think that will give the reaction, that result in the fibrous formation and adhesions, and increase the failure rate. So I would not go for. I'm with the non-penetrating deep sclerectomy. Although there is a review from I think from Jeddah, and about this, and they said the deep sclerectomy, penetrating deep sclerectomy is as success as non-penetrating. Even in some cases, they think it will be better to have a micro perforation. But I'm with an idea of not to perforate.
Good idea. Any question? Any more questions? If no more questions, thank you very much, Dr. Faisal. Thanks for audience. See you again, inshallah.